hi everyone. My name is Haley. I am currently serving as a student experience officer on the Europub Health Students and Alumni Association Board. I am also a current EPH student, having completed my first year in Dublin and now specializing in leadership and governance in Maastricht. And I am also the moderator for today's session. I personally am very interested in our topic today and how emergencies and disasters are handled through a public health lens. And just a little bit about me, I've personally completed research regarding Venezuelan migrant women and girls' experiences with xenophobia and its impact on sexual exploitation. So, a little bit more in the humanitarian crisis emergencies. But to begin, I'm just going to run through a few housekeeping items. The session is being recorded as it will be uploaded to our channels following its completion. We will also be taking attendance, as those who attend at least 3 out of 5 of the talks this academic year will be able to receive a certificate. So please make sure to fill out the Google form that I will circulate around in the chat. As well, the session will be about an hour and a half long, with some time for questions after each speaker. So if you do have any questions, we'll reserve about 5 minutes for those after each talk. So today we have 4 amazing speakers with us, and we'll start by introducing our first speaker of the day. So please welcome Professor Dr. Rafael Castro Delgado, an emergency physician and accredited full professor of emergency medicine at the University of Oviedo. With over 20 years of experience, he combines frontline clinical practice with teaching and research in emergency and disaster medicine. He is the only pre-hospital emergency physician in Spain accredited as a full professor by ANECA and has published more than 130 scientific articles. And he also leads the national and international research initiatives, including collaborations with the WHO and the European Union, and has played a key role in advancing pre-hospital triage and disaster response systems in Spain. And he is also the coordinator of the Erasmus Mundus Masters in Public Health and Disasters. So a similar one to a lot of the students here. So with that, I'll now hand it over to you, Rafael.
Okay, thank you very much, and thank you for the invitation for this so enthusiastic initiative with public health students. I combine teaching with clinical practice and research. I work in the pre-hospital setting, but I am also university professor related to disasters and emergency care and public health. So the topic for my conference will be research and conflict. How we can establish really a link between research and conflict, how research is affected by conflict, and how conflict is affected by research. So there are many international organizations that monitor conflicts worldwide. This is one of very well-known organization, ACLED. And we can see that while the war is changing, we are in a risky war, and many countries are under a conflict situation, as you can see in this map. Even the conflict level, we can grade it from extreme high, turbulent, or low, inactive. Of course, with the very first country, with Palestine, but we go on with Myanmar, Syria, Mexico, Nigeria, Brazil, Lebanon. So this is a reality. We have conflicts worldwide, and from the public health approach, we have many things to say related to conflict, and also from the research perspective. This is our recently we have published a manuscript related to research and conflict, following the example of Ukraine. And we have established a framework on how conflict affects research. So when there's a conflict in a country, in any country, of course, this conflict means that there's a financial constraint for the country because the priorities for the government change. Also, there's a damage to infrastructure, to research infrastructure, but also there's a disruption of the academic institutions. I mean, the daily follow-up and daily working time for research is changed because the priorities for the countries change. And of course, there's a staff reallocation. I am a clinician and a researcher. I'm sure that if here in Spain we have a conflict, I will be working in my ambulance and I will not be working as a researcher. So there's a staff reallocation in conflicts. But let's say that politicians or policymakers, they should know that research have an important is an important tool for conflict. What is the impact of research? Well, we can use research to monitor needs and conditions. This is very important from a public health perspective, because once you monitor needs and conditions during a conflict, you can identify new needs that may arise and that you have to focus on. Also, research is a tool for informing policy and practice. Research is a real tool for policymakers related to health in conflict and in non-conflict countries. And this is something that we have to try to convince our politicians. Also, conflict research can be used to monitor humanitarian interventions and their impact. So it's not just a matter of describing what's going on and monitoring, but also how humanitarian interventions are affecting the population needs. And also, of course, the best evidence-based practice. Because when there's a conflict or even a disaster, sometimes the decisions are based more on economical aspect, but not on best evidence-based practice. So what have we seen in Ukraine? Well, there in this QR, you can access to our manuscript. Following the example of Ukraine, we map research trends and gaps in Ukraine emerging medical services. I mean, what was our main objective? It was to monitor how the type of research that was done was changing depending on new needs that were arising in Ukraine. After a systematic review, we screened a total of, we included 62 manuscripts. And then I will not go very in deep through all our manuscripts, but here you can see how the main topics that increased research were disease-specific care in conflict, medical evacuation systems. I mean, for instance, if we focus on medical evacuation in Ukraine, there was a need for medical evacuation from conflict areas to non-conflict areas. So at the same time as these need arise, we have identified that there's an increase in the manuscript published focusing on this need. So it's not only that the conflict make us to see new needs, but also that the research can be a very interesting tool to see how we can improve our response. So, because at the end, when we're talking about research and you and public health students, you should be aware of this because the purpose of research is not just to describe the war, but to change it. In the sense, this phrase is cited by many scientists, but at the end, it is based on a Karma's thesis that says that philosophers have only interpreted the war in various ways. The point, however, is to change it. So I want to be very, very brief. And my main objective with this talk is to encourage all public health students to do research, even in conflicts, because research is one of the best tools we can have to improve the response, to identify needs, and to monitor what we're doing and what is happening to the population. Here, with this QR, you can access to our Erasmus Mundus Master in Public Health Disaster, which is financed by the European Union. And well, the call is open right now until end of the year, I think to remember. So there you can have more information related to how it is structured. Thank you very much.
Awesome. Thank you so much for that insight into conflict and research. So we'll now move into our question period. So if you have any questions, people viewing this, please feel free to put them in the chat or raise your hand. Very just an informal discussion. So if there's anything, I can start getting the ball rolling. I know one question that I always have when it comes to research, especially in what is often considered like the global south or underdeveloped countries, how do you balance that like ethical obligation of providing the research back to the community, or making sure that you're not engaging in that kind of like white saviorist aspect that can come with sometimes research happening more in the developed countries on these underdeveloped countries?
I didn't catch the idea. Please repeat it again. I didn't catch the question.
Yeah, I'm just wondering about just like the ethical aspects of doing research on like underdeveloped countries or those that are in like humanitarian crises. Sometimes we often do research in the global north that is on those other contexts, and sometimes it's that the research isn't provided back to the communities or like the results. So how do you work to make sure that you're fulfilling those kind of like ethical obligations?
The main idea is that when you have a specific conflict in a country, then the idea is, okay, what's going on in the country? How can we monitor what's going on in that country? Never mind whether it's a high-income country or a low-income country. We're focusing on countries and in conflicts. So once we know that, the idea is to apply scientific approach to the problems that may be arising in that specific country. And once we are applying the scientific approach, then we identify needs, but that's the first step, to identify needs, to monitor needs, and then also we can use research to see how humanitarian action is being implemented and what is the effect on the population. Because sometimes we try to, let's say, to intervene with some humanitarian actions that at the end we haven't got any result, and it has been very, very expensive. So there's a cost of opportunity in the sense that we have to decide where to allocate our efforts so that we improve population health.
Yeah, thank you for that answer. I think that answered it very well. Does anyone else have any questions that they would like to ask? You can drop them in the chat.
I have a question. I don't know if you can hear me well.
Yes.
Hi. First of all, thank you. It was really interesting. My question is about the availability of data, because I know that I guess in these situations it's hard to like, it's not a normal situation. So how do you manage to get all the data that you need?
That's that's the main limitation you are trying to do research. First, what we did was a systematic review in the sense that what's the rest of the people doing in Ukrainian conflict. But once you want to do research, in every document, manuscript, or whatever, you have to write the limitations. So the main limitation is the reliability of data. For instance, recently there has some very few manuscripts published related to Gaza conflict, and one of them even was published in Lancet. So we all understand that the data may have some type of bias, but you write it in the limitation sections because that's the best you can do. So sometimes when you're, for instance, if you are doing research with clinical trials, then of course the reliability of the data, you have very strict. But when you are doing research related to disasters or related to conflicts, we all know that the reliability of data may not be as good as other more classic scientific approach. That's why it's so difficult to publish a manuscript related to disasters and conflicts, because the reviewers sometimes they say, well, what about their data? How do you demonstrate that they are reliable? Well, sometimes we can't demonstrate, but the added value of the research sometimes is higher than the added value of another research that has a very good data, but it's just another more research related to the same topic.
Thank you.
Awesome. Any other questions for our speaker here today? Seeing a comment here, it just says, thank you for the great input. I was wondering if you could share one prominent experience when the research shaped the humanitarian response on the field, if you see that in the chat.
Yes, there was a PhD thesis that was in Karolinska after the Haiti earthquake. In the humanitarian field of knowledge, we were somehow shocked because there were a huge response with probably not very good results. So after that, they analyzed what was the best approach when you want to deploy international teams. In fact, previously it was called field hospitals, and now they are called emergency medical teams. That it's a WHO initiative, and it is based on scientific background, trying to analyze what is the best way, the best time to arrive and what should be your objectives depending on the time when you arrive after the disaster. So that's a very good example of how, let's say, research made changes in the military response on the field. The one related to emergency medical teams that was previously called field hospitals, and now there's a very important and interesting initiative that WHO related to emergency medical teams based on research.
Amazing. It looks like you answered the question. Well, so I think that brings us to the end of our question period for this. I'm not seeing anything else in the chat, but if anyone does have any other questions for Professor Rafael, please feel free to email them to me and I can send them along. But with that, thank you so much, Rafael, for joining us today. I know that you do have to head out, so no worries, but thank you for volunteering your time to speak with us today. We really appreciate it.
Thank you very much. It was a pleasure for me to share this time with you. Of course, you can share my email with any questions I may respond. And thank you very much again. I'm sorry not to be able to keep on the meeting.
All good. Thank you again so much. All right, we'll move into our next speaker then here today. And it is a pleasure for me to introduce Professor Andrew Lee, who is the Professor of Public Health at the University of Sheffield. So some people in our audience may have already had a class with you or worked with you before. But for those of us who weren't at Sheffield, this is a great opportunity to hear a little bit more. So with an extensive career in emergency and disaster response, both in the UK and internationally, he's also worked as a humanitarian in post-war Afghanistan, during the tsunami response in Sri Lanka, and following the Typhoon Haiyan in the Philippines. His research in emergency settings spans the UK, Sri Lanka, and Nepal. And during the COVID-19 pandemic, he served as the National Incident Director in the UK and currently works with the IANPHI and the WHO on the Global Health Emergency Corps Initiative. So with that, please join me in welcoming Professor Lee. Thank you for joining us today.
Thank you very much. Good evening, everyone. Thank you so much for the invitation. It's always nice to be asked, so I appreciate your time and kind invitation. Okay, glad to hear some of you are interested in management and leadership as well. Is that right? Did I hear right, Haley, from your side?
Yes, some of us I know are at Maastricht doing the governance and leadership track, so we're definitely interested.
Yes, and in 10, 20 years, you guys might be the future leaders, public health leaders out there. In fact, I do even know of some of your illustrious alumni who currently work with me in the WHO, heading on health emergencies. So I wanted to share with you, taking a step away from Professor Rafael's talk, not so much for the academic side, but actually insights from the last 25 years working in disaster management, really. So it's a short 15 minutes, so let me get a crack on. The one thing that defines public health emergencies, okay, is complexity and scale, okay? The trouble about complexity is that it is not just a simple solution, a quick fix that you're going to find. And the trouble is, especially for those of us who come from medical backgrounds, we tend to see it in a very narrow medical lens. It's a medical fix-it. It's never like that. Disasters are whole of society events. They are whole of government events. They are multi-sectoral in nature. You know, they span everything from the economy to psychosocial impacts to environmental impacts, and not just health. Okay, so it's really, really complex, and they're all interdependent. All right. The second issue is that of scale. And something I've told our disaster management class in Sheffield, we're not talking about a pile-up on the motorway with 4 or 5 vehicles and a dozen people injured or killed. We're often talking about events where you have tens of thousands or hundreds of thousands of people affected. Okay, and your ability, and I'm going to say you, I mean if you're working for a charity or the government or a ministry, for example, your ability to respond to that scale is actually very limited. Just think about it, okay? An example I've given in my class as well before is back in the UK a few years ago, we had floods in the south of England. We had tens of thousands of homes flooded. And we had people saying, why hasn't the government sent out the troops to build a sandbag wall around my house to protect my house? And then you just do the sums, okay? For one house, how many sandbags do you need? Hundreds? Okay. How many men do you need to fill those hundreds of sandbags for one house? Now multiply that by, let's just say, 10,000 homes in a city or a town. Multiply that by 5 or 6 or 7 towns and cities affected, and you suddenly get a sense that, okay, we're looking at millions of sandbags. So even if we deployed the entire British army and the Chinese army and the US army to fill sandbags, we still wouldn't have enough sandbags. That, my friends, is the issue about public health disasters. Scale. And we saw it in COVID, didn't we? Public health departments around the world were swamped, overwhelmed. All right. So complexity and scale. So there's a problem then, isn't it, in terms of how governments and ministries approach disasters? Because we're so used to a centralized top-down control. Okay, we will tell you what to do. The government will provide. But I'm here to tell you, my friends, that that's the wrong approach, because it doesn't address both issues, complexity and scale. Right? So how are we going to address complexity? Firstly, building these top-down vertical silos of command and control doesn't work, okay? Because you end up with many silos in the fire service, in the police service, in the military, and in the hospital sector, and the public health sector, and so forth. And these silos all do not work very well. What you need is horizontal integration. So what happens at the local level? What happens in your communities? What happens in your towns and your neighborhoods? That's not a top-down thing. It's a horizontal approach to how you respond to a disaster. So the community is key, isn't it? And not only is involvement of the community key, it's also involvement of multiple sectors at that local level. It's a whole of government, whole of society approach. And don't forget, when we talk about communities, communities are not all the same. We're not all configured the same, are we? Every community is different. We live in communities of communities, and the needs of every community, every population subgroup is totally different. Okay, so complexity. It needs that local layer. It needs that local interface. The second bit then, okay, so you got the complexity, and then the issue of scale. All right, how do we address scale? And again, I really told you can mobilize the whole of the state apparatus, and you still probably wouldn't have enough. But that's if you see your population as victims needing help. But what if the population weren't victims, but they were helpers? That changes it, doesn't it? How do you then mobilize the population to work with you, to help you? And in many disasters, we see a phenomenon called spontaneous community responders, or community response, SCR. We see it in every disaster, and people coming out of their own goodwill to help, to provide shelter, to provide food, whatever it might be. How do we harness that? How do we help bring in that community response into formal state response? We haven't figured that one out. We haven't figured out that one out yet. Okay, so there's a gap. So it then begs the question: what is the role of government? Is the government there as director telling people what to do? To an extent. Is the role of government there as a regulator to regulate what is done? Yes, to an extent. Okay, you want things done in a safe way that protects and safeguards children and women from abuse, or to make sure it's not criminal. Yeah, so you need those safeguards. Is the role of government as funder? Yes, definitely in disasters. Disasters are very expensive events. There's a role for government there as a funder. But the most important role of government there is as an enabler. So when you guys are leaders, public health leaders in the future, ask yourself, how am I enabling communities in this situation? Okay. So in Haley, you mentioned the white saviorism issue. It's not so much the saviorism. Yes, it is an issue and all linked to neocolonialism, but let's park it for a moment. But if we think to our own communities, it is still that very top-down mentality of government doing to you. Yeah, But how do we change that mentality where the government is the enabler? We are enabling and working with you. It won't surprise you to know I'm a big believer in prevention being better than cure, prevention being cheaper than cure. So when we talk about disaster management or public health emergency management, the first step isn't responding. The first step is actually how do we stop the thing happening in the first place, isn't it? Okay, so, and it is not just investing in emergency responders. No, it's investing in public health, the whole of public health. Okay, and it's not just emergency planning. I say the whole of public health because the vulnerabilities of our communities, the vulnerabilities of our communities are due to structural factors, are due to racism, to discrimination, to poverty. Yeah. It affects their access to health. It affects their access to financial resources. It affects the ability to get jobs. It affects their literacy. It affects the ability to access information. It affects how they can recover or protect themselves from emergencies. So the first step when we talk about prevention, it's public health. It's us. Yeah. We don't need more hospitals. We don't need more doctors. Apologies to my medical colleagues out there. Yeah, we need more public health. But as we are finding even now around the world, governments are disinvesting in public health in the aftermath of the pandemic. And it's a really, really scary time. There's the focus is elsewhere. The governments are withdrawing in, the public mood has changed. And it's a real challenge for us as public health practitioners, how we continue to be powerful advocates for public health. Yeah. And my very last thought with you is emergency response doesn't start in the response phase. Emergency response starts before the event. It goes back to prevention again. Okay. So I hope you've picked a few thoughts from me today. Complexity, scale, okay. Thinking about our role, okay, as leaders as in the community or in government. Yeah, what's our enabling function? But most importantly, how do we work upstream? How do we prevent that event in the first place? Okay. Thank you very much, and I hope that was of some use to you. Happy to take questions.
Amazing. Thank you, Professor Lee. And like you said, we'll move into our question period. But yeah, that was absolutely fantastic. Getting to hear a lot about those different aspects of public health and engaging in emergency and disasters. One thing that I was kind of thinking of was, we talk a lot about especially in this Maastricht governance and leadership track, we talk a lot about frameworks and how they can be applied. But I've always had the question of, we always talk about these frameworks, but how are they actually being applied? And we talk about helping the local level. So do you have any insights into how to kind of bridge that gap in having those frameworks, but also making sure that we are empowering the local communities and having their voices heard more?
Yeah, definitely. So the problem we've got at the moment is who's coming up with those policy frameworks? People at the national government level, okay? But who translates it at the community level? It's not the national. And in many countries, we've got what we call the policy disconnect. Yeah, you may have all those wonderful ideas up at national level, but unless you have an interface at the sub-national level, at the local level, all those ideas at the top are just wishy-washy dreams, pipe dreams, effectively. Okay, so you need strength when you talk about strength in governance. Basically, you need strength not just at the policy making level nationally. You need strength at the implementation, at the translation into action, translation to practice level, and that is much lower down. So you need to build up layers of government and public health at the interface with the community. Because seriously, national government doesn't interface with the community. It's not national. It's subnational. Yeah. So when you start thinking about policy, do think about how do you translate that? How do you communicate that down from the national to the local? How do we bridge that policy disconnect?
Yeah, I think that's some really good insights because I feel like, especially in our program, we talk endlessly about these frameworks, but that is always a question of how are we making sure that we are getting to those communities. Following up, Beck has asked a question in the chat. And she's asked, how can this horizontal approach be implemented for very remote communities such as rural Australia?
Yeah, that's a good question. I mean, firstly, it comes back, as I said, if you're working at the national level or hopefully at the state government level, is having that awareness that you really do need to engage and want to engage with those communities. All too often, I see lazy policy making uh, all around the world, basically. Okay, um, where we come up with a one size fits all, very simplistic policy and think it'll work for everywhere. Okay, if you know. Let's just say you're working with the state government in Western Australia or South Australia, wherever it happens to be, and you know you've got communities out there, rural communities, and you want to reach out to them, and you want to involve them, and you want to do that public engagement and consultation and co-production. If you're prepared to do that and you're thinking along those lines already, you are downside further along than some of the others who aren't even at square one. They're not even thinking about that. Okay. So back the fact that you're asking the question, that's really encouraging. Okay. Because if you ask that question, it leads to the next bit. Okay, what am I going to do about it? And then it'll get you on that path to looking at how do you engage those communities and go down that co-production route. Right.
Amazing. I think that answered most of Beck's question. I hope she agrees. Is there any other questions from our audience? You can either put it in the chat or just feel free to unmute or raise your hand. There's one in the chat here. Says, thank you so much for this. I understand that governments should be part of the process, but in certain contexts, we see that governments are not only not cooperating, but are standing against the relief process of people for different reasons, bracket, political, military. Do you think that we can rebuild our frameworks to work around governments and build relief processes without them?
Fantastic. Really great question, Jamil. I would say, firstly, public health is not just a science, a technical science that you learn at university. It's also an art. Public health is political. Public health is politics. And in politics, you will have many, many, many different actors with many, many different agendas. Whether you like them or not, whether you agree with their politics or not, you've got to find a way to work with them. And working with someone of a different political persuasion or agenda doesn't mean that you're subscribing to them or that you're supporting them. No, no, no. That's not what I'm saying. But learning to work with them, finding common ground, and that's where we gain traction. Okay, that's where we gain traction because there's no point. I mean, that's one of the criticisms sometimes of international agencies like the WHO. They go into countries and wave their frameworks and tell people implement it, implement it, implement it, and countries pay them lip service. Yeah. So there's a real art and skill to playing the politics game, and something that you will all have to learn if you've not already got it when you go back out into that public health world afterwards. Okay, learn the art of wheeling and dealing and collaborating with people of different agendas. Okay.
Amazing. Looks like Jamil appreciated that answer. Does anyone else have any other questions that they would like to ask Andrew?
Yes, I have a question. Hi, Andrew. It's so
Hello.
nice to see you again and uh, enjoy your talk as always. So today in Maastricht, we were talking about policy window and how limited time we have after a shock to change things and convince governments or who are resisting changes to implement some improvements in health systems. Now that COVID time has passed, and as you mentioned, so many countries are cutting their budget on public health. Do you have some tips for us that we can work on? I know that you mentioned that we can work on inequalities and all of other aspects of public health that are related, but for making public and communities ready for the next shocks, next pandemic, or any changes that any disaster that might happen.
Yeah, it's difficult, and you will all have learned about Kingdom's policy model and the policy windows and stuff, all good stuff. But don't forget, if this was a political science masters, if you guys were studying politics, or if you were working as a lobbyist in governments or for think tanks or for the private sector, you would learn that you can actually shape the policy window and shape the policy streams, basically. And that's essentially through advocacy. And that comes back to, how do you find allies? How do you find politicians or these key policymakers that you can, over time, build relationships, get your narrative across? What's your public health narrative? Okay, get your narrative across. And once you have got the first ally, how do you get your second ally and the third ally? How do you build a coalition? How do you then build momentum? If you see what I mean. So don't just assume, oh, COVID's there, Windows there, COVID's gone, Windows closed. It's not like that. We can shape those windows, those opportunities, but it takes time and it takes effort. And it's not easy.
That was very, very helpful. I didn't expect that, but yes, we can make those windows. Thank you.
Sounds like Fresha enjoyed that answer. Definitely very insightful for all of us here. And like she said, we've had a very full day at Maastricht here about health systems. So we have this fresh in our heads. I'll just leave it open for a second if there is any last questions or comments that anyone would like to ask Andrew. All right. If not, then I will just say thank you again so much for joining us. It's been a pleasure. All those who went to Sheffield last year or in years before have definitely raved about you. So it's been great to hear it for ourselves over here. So yeah, thank you again so much for volunteering your time with us today. I know that you also have to go as well, so no worries. And if anyone does have any questions for Professor Lee, please feel free to send them in the chat and I can send them along as well.
That would be lovely. And thank you once again for the invitation. And I can see Gabriel on the telly. Hi, Gabriel. Good to see you. It's always lovely to catch up with all of you guys.
Well, he's our next speaker, so you might hear a little bit of the beginning as well.
Okay, lovely. Take care.
Thank you again. So, as you all already got a little glimpse, it's now my pleasure to introduce Gabriel, who has been working with the Austrian Red Cross for the past 7 years in roles ranging from paramedic to coordinator of volunteer staff. He studied business, economics, and social sciences at the Vienna University of Economics and Business, with a focus on modern growth theory, innovation, and strategic management. He is now currently an EPH student at Maastricht University, specializing in governance and leadership in public health, so alongside myself. And today, he'll be speaking about current trends and innovations in emergency medical services and their relevance for European health systems, as well as their potential application in disaster settings. So everyone, please join me in welcoming Gabriel. Take it away. Oh, sorry, you're muted. There you go.
Okay, I hope everyone can hear me and see my presentation. I can see you, so Haley, could you please just tell me a little quick if it works?
We can see you and we can hear you. It's all good.
Okay, thank you very much. So first of all, thank you very much, Haley, for the invitation and for organizing the EPHSA talks. I will today focus on emergency services systems across Europe. This is not directly related to emergency response and emergency management, but often EMS are the first in line when it comes to responding to disaster. And it's also important to keep the business continuity up of EMS systems during disasters. So my presentation will be divided into 3 parts. The first part will be general information on emergency medical service systems. The second part will be on current challenges. And the third part will be on innovations. But this part will rather be short out of time constraints. So So let's start in. So first off, as I said, general information on EMS systems. So there's a common saying, if you know one EMS system, you know one EMS system. And this means that EMS systems around the world are very, very different. And even in Europe, they're very, very different and diverse. They differ in how personnel is trained, how fragmented the system is, and even like on competencies and so forth, and the legal framework as well. So general information about emergency medical services. So quick definition, it's a comprehensive system which provides the arrangements of personnel, facilities, and equipment for the effective, coordinated, and timely delivery of health and safety services for victims of sudden illness or injury. Sounds very complicated at first, but basically it just means responding to people who are ill or injured in a timely manner. The goal of EMS systems is as I said, providing timely care to victims and prevent needless mortality and long-term morbidity. And you will see later that this is one of the problems that EMS systems face today, that their initial role has shifted. Other basics on emergency medical services. Today's global EMS, they are really advanced, and the WHO regards them as an integral part of effective and functional healthcare system. Often in healthcare systems, we don't talk a lot about EMS systems, but they are important as well, especially because they're often the first point of contact for a patient, especially a patient which has a severe illness or severe injury. They're also politically important because if something goes wrong in an EMS system, it's often in the media. Delays in access to treatment, now it becomes very interesting, are typically understood by the public as a matter of life or death. But you will see later that this is not the case in most cases. Interesting also is that the research and the comparison of EMS systems is scarce. As I said earlier, EMS systems are very, very diverse. So it's also hard to compare them. But there is more research on cross-border collaboration of EMS systems. Also, it's hard to measure the performance of EMS systems. I will not focus too much on that today, but just very briefly, one of the main performance indicators for EMS systems is the response time. But today, EMS systems are so complex that this indicator isn't a good indicator anymore. Now, one of the most important parts of EMS today is that it acts as a gatekeeper. A general gatekeeper to the health services, but also to secondary and tertiary care. And there are main differences between different EMS systems around Europe. For instance, in Germany, I visited the German Red Cross a few weeks ago. And what I've noticed there is that the role of the EMS is more and more in being a buffer for the social system which is failing. So they're responding to a lot of calls which are not life-threatening emergency or sudden illnesses, but rather like social calls. So they have to advise them, consult them, and support them in different ways. In comparison, for instance, to the Netherlands, where I'm right now, is EMS is one of the only ways to get access to a hospital. Otherwise, you need to be admissioned by a general practitioner. So the role of EMS as a gatekeeper is very important to bear in mind, and it's becoming more and more of a gatekeeper. Okay, so just very briefly, there are basically two types of EMS systems. There's the Anglo-American load and go model. This is the one you know from all the movies. It has the focus on bringing the patient as quickly to the hospital as possible. So you might see in movies that when they're performing CPR, they're loading the patient into the ambulance while still doing CPR and while driving to the hospital. This is a bit different in most European systems, which are called the Franco-German systems, and they are more about staying and stabilizing the patients. And they rely heavily on mobile medical doctors and not just paramedics, who provide advanced medical care on site. And you will see later that this is the system in most of the European countries. Worth noting, today in Europe, we mainly have hybrid models. In Europe, usually on a trauma call, a severe car accident, they follow the load and go model. There's something called like the golden hour of trauma. So they try to get the patient as quickly to the hospital as possible, just because they don't have the diagnostic resources on site, like a CR scan. But for other calls like cardiac arrest or heart attacks, they rely more on like supporting the patient on site. Here we have a map of how reliant systems in Europe are on emergency medical doctors. The grayer, the more dark gray the countries, the more reliant they are. So you can see Germany and Austria, where I'm from, are relying heavily on emergency medical doctors, whereas in Italy or in Romania, they rely less on emergency medical doctors. Also in Ireland and Cyprus, the only two systems in Europe which are considered to be similar to the load and go system in the US. Also interesting, in some countries, ambulance services are even considered primary care, which has some advantages in governance and financing, like Slovenia and Lithuania. And in other countries, they are provided by local governments, by federal governments, or even by NGOs. Many EU countries also have integrated dispatch centers. This means they have the same dispatch center for the fire brigade or like ambulance services. This is not true for every country, but this is kind of considered the gold standard today. Okay, now coming to the challenges for EMS systems today. So this is not a complete list, but it's a list of one of the most, like a few of the most pressing challenges today. So as for most areas of public health, the population health trends, demography, and is one of the main issues. Like the population in Europe gets older and older, which results in more and more calls. Also, multimorbidity gets more frequent. This means patients with having more than one disease. So most of the calls today in EMS like respond to patients who have like 2, 3, 4, or even more diseases at the same time. Financial instability is a problem, which also relates to legislation. Funding mechanisms for EMS systems vary greatly between European countries. For instance, as an example, in Austria, they are financed on a municipal level, but emergency medical doctors are funded through a state level. So it's very fragmented, and that's also one of the issues. Also, like sometimes there are NGO systems and they lack financial resources. Another point about legislation about training and the qualification and the competences of paramedics. So in many countries in Europe, paramedics don't have a lot of competencies, especially in the countries which heavily rely on emergency medical doctors. In these countries, they can't administer a lot of different medications. Personal fluctuation is a big one, and in EMS, paramedics don't stay in the system for very long. They usually don't do it their whole life. Young paramedics come, and and they stay a few years and then they are usually gone and follow a different profession, which is a big problem because the more experienced ones typically leave. Another one, fragmentation of dispatch centers, less a problem in Austria, but a big problem in Germany. And sometimes dispatch centers in Germany are organized on like municipal levels or on like city council level, sometimes on state level. It's very, very different. The increase of low-level events, another challenge. Today, the calls tend to be less urgent than they were decades ago, which leads to not a lot of ambulances being sometimes like free for responding to actual life-threatening events. And also in Europe, especially limited cross-border coordination. So if you have, for instance, an emergency at the border between Austria and Germany, still the Austrian ambulance that needs 30 minutes to respond might come instead of the German ambulance, which is like 2 or 5 minutes away. And the only initiative that the EU kind of like did in this area was the 112 emergency number, which is standardized in the whole of Europe and can be called anywhere. And typically, just as an interesting side fact, if you call the 112, you typically reach the police in the country and they will redirect you to the ambulance services if you need them. So now coming to a case study for one of the challenges about telecommunicator CPR in Germany. So as I mentioned earlier, dispatch centers in Germany are very fragmented. And you can see on this map, I'm sorry, it's only in German, but I will translate it for you. So basically the green ones means that the dispatch center is using standardized and structurized call taking, which means that they use a certain algorithm to analyze your call and to prioritize it. You can see in the green areas, they use the standardized and structurized systems. In the yellow ones, they are planning to use them. And in the red ones, they don't have them at all. And the rest is means that there's no data on it. So you can see that in a lot of the parts in Germany, there's still no standardized call taking, which leads to subjective behavior of call takers and can also lead to problems for telecommunicator CPR. So what is telecommunicator CPR? It's a concept which is very old already. It's from 1985. So it means when someone has a cardiac arrest, that the call taker gives you instructions on how to perform CPR. And this is not the case in all parts of Germany, which is, I think, a crazy fact. And this concept was developed because the biggest problem when there's a CPR call, like a cardiac arrest, is that the laymen, so the bystanders, have great insecurity to actually perform CPR. And the call taker should help them to give them clear instructions and guide them through the process. Because every minute for a cardiac arrest counts. Because in every minute there's no CPR performed, heart cells and brain cells die. So it's very important to start as early as possible. And a problem for call takers still is to correctly detect cardiac arrest by the call taker on the phone. So success factors for telecommunicator CPR are the training of call takers and usage of structurized algorithms to detect if it's actually a cardiac arrest. Strict internal guidelines, which also relates to the standardized procedures. And existence of external guidelines. This could, for instance, be a law or a policy saying that you have to implement these systems or that all of the dispatch centers have to integrate the same system. Barriers for implementation of that is a high number of parallel calls. So if there's many calls happening at the same time, and call takers are stressed. They might not perform telecommunicator CPR, or they might need to take another call. Staff shortages are also a problem, insufficient qualification of call takers, and sometimes lack of technical equipment. There's specific software that you can use to support the process. This is what this relates to. So to conclude, in Germany and in many of the dispatch centers, there are no standardized and structurized procedures for call taking. And this also means that very often telecommunicator CPR, is not performed. Telecommunicator CPR is related with better outcomes for patients suffering from cardiac arrest, and it should be aimed to implement it across the whole of Germany. So for that case, for the reason, as an organization in Germany, which identified this problem and which tries to promote the use of telecommunicator CPR. And from 2014 to 2021, it has risen from 12% to 33% telecommunicator CPR performed in German dispatch centers, which is still very, very low, I must say. So Germany is not a good example for telecommunicator CPR. And also, more than 80% of telecommunicator CPR is only on half of the dispatch centers performed. So half of the dispatch centers in Germany do very well, but many of the others do very, very bad. Okay, so this is the case study for presenting one of the challenges that the EMS system faces in Europe. Now, just very briefly, because I see I'm running out of time, on innovations in emergency medical service systems. I initially also wanted to include a case study for that, but that would just be too much for this little time. So I'm just going to give you 4 examples of current innovations. One innovation, which seems crazy at first, is electronic patient case reporting. It's not that common in EMS systems that patient records are recorded digitally. And I know from my experience in Austria, most documentation is still done on paper, and there's no integration between the hospitals and the EMS system. In an ideal world, it would work that way, that when assessing the patient, I'm already doing my documentation, and then the vitals, for instance, the vital parameters of the patient, blood pressure and so forth, I take from the patient, are instantly transmitted to the hospital, and they already know what the patient has before the ambulance arrives in the emergency department. Also drones. I've written recently that drones are applied very frequently in the Ukrainian war, mainly for delivering medical products to the front lines. And in Austria, for instance, there are pilot projects for delivering defibrillators through drones. This is still very early on the research, but I just wanted to give you an idea that there is research done on drone usage in emergency medical services, but they are not implemented today. Artificial intelligence is a big one, especially for diagnostics. There are several studies done on how artificial intelligence can support paramedics in making more accurate decisions for strokes, for instance, or for ECG assessment, and mainly for diagnostics. And another one is telemedicine. And this is the innovation where I wanted to initially make the case study on. And I wanted to make the case study on emergency doctors telemedicine, which is a project which has been implemented in Aachen, not very far from Maastricht, about 15, 20 years ago, and is now becoming more and more relevant also in other systems around Europe. In Austria, there have been trials done. It has been implemented partly. So what does this mean? This basically means that you as a paramedic can video call or normal call an emergency medical doctor who is who you can talk to and who can help you make a decision about the patient. This could mean that he helps you to which hospital should you go to, or helps you to which medications should you administer, or also he could give you instructions which are out of your legal competencies that you can apply. So, for instance, if you're only allowed to use one dose of a certain medication, the emergency medical doctor could say, "I please do a second dose," and this would be then legal. In Aachen, this system is so advanced that they almost have no emergency medical doctors on ambulances, on units anymore. So most of the calls are done just by paramedics, although they don't have a load and go system, with the help of emergency medical doctors. Okay, so this is the end of my presentation. I hope you enjoyed it. Out of time constraints, this is just a quick overview of EMS systems with a few things that I found interesting. I'm now open to any questions that you might have. Thank you very much for your attention.
Amazing. Thank you for that overview of the EMS systems. I think it's been great to kind of get all the different perspectives, and then even here getting that more localized level of EMS services in Europe. And it's great to hear your real life experiences. I'm going to start with maybe a more personal question, and just ask, like, what got you involved in wanting to work in paramedicine and with the Red Cross just individually?
So it was my granddad who already worked at the Red Cross. He worked at the Red Cross his whole life. And I found it interesting. As a kid, I was sometimes at the Red Cross when he was still working there, and it intrigued me. And I didn't think that much about paramedicine at first, because in Austria, the Red Cross is far more than just like offering EMS services. It also offers social services, blood donation services, and so forth. So I was just joining the Red Cross, and then I got into it and I enjoyed it a lot.
Amazing. It's great to kind of see how those family connections also play into it. Omei has a question. How reliable now is AI as an innovation? Do you think it could be really useful considering the most calls are non-acute?
Okay, so the usage of AI in EMS is still in like exploring phase, like in a piloting phase, test phase, and you have to be you have to be aware that it's very difficult to do research in EMS, mostly because of ethics constraints, and also like how do you document cases, how do you perform your study methodology. And so it's very hard to do trials, just as a side note. And that is also why it will take a long time till these AI tools will be actually implemented in EMS, I think. What has been done, and also because it's, as I said, easier to do research on, is AI in dispatch call centers. So what some studies investigated was how can AI help me do triage on calls. So triage means like prioritizing and categorizing calls. There's research on that, and I'm very confident that in the future AI tools will support call takers while doing our prioritizing calls. and will in that sense also help the whole EMS system, because calls are more accurately prioritized. Another potential usage of AI is, as I said earlier, diagnostics, also in relation with like telemedicine. So in an ideal world, as I say, I do an ECG if I don't have a doctor on the call, and he will analyze the ECG through the digital tool. So the doctor will not be there, but the doctor will still analyze the ECG. I'm not saying that this should be done like for the most life-threatening ones. Like in these cases, there should be a doctor on call as well. But it could help improve outcomes by just like more routinely analyzing ECGs, so that you don't miss that much. AI has been proven to be a great diagnostic tool. Teleradiology in hospitals is becoming more common, and there are studies that suggest that AI is actually better in detecting certain diseases than actual doctors are. I hope this answered your question.
Amazing. Thank you for that insight as well. Omer, if there's anything you want to add, feel free to. So the next question is, can you please talk about the cost effectiveness of such technologies like telemedicine, for example? Do you think they can be implemented into resource limited settings?
I think this is the whole point of telemedicine and EMS. Like EMS systems are very expensive because of capacity building. You have to build capacities that you are able to respond to calls also when there's high demand, because you never know how many calls you will have on a day and at a certain time. So you have to build resources that you are able to respond to all urgent calls in a timely manner. Telemedicine can help because it reduces the need for that much capacity. Because, for instance, you have like in an area of 100,000 people, and would be very common for Austria, you have one emergency medical doctor. This doctor responds to one call. 5 minutes later, there's another life-threatening call, and there's no emergency medical doctor available. In that case, you could use telemedicine to improve patient outcomes. Now coming to cost effectiveness, especially having emergency medical doctors or like very experienced and qualified staff in rural regions is very expensive, because there are not many cases, but you still have to build capacity to respond to life-threatening or very urgent calls. And in these cases, telemedicine can help to still have a good patient outcomes, but without a need to have an emergency medical doctor available in this region. Talking about other regions of the world, more rural regions and regions who maybe don't have that many financial resources, they can also profit from telemedicine, because you basically only need one doctor for a bigger area. So it's and staff costs are the most expensive costs for emergency medical services, as it is in most of like health services. I hope this answered your question as well.
Amazing. And we'll go into our last question from Manuela. You mentioned there is a high turnover of EMS staff. In your experience, why is that? And do you think the sector should accept this reality and find ways to embrace it?
I think it's very different depending on which country we look at. But one thing that I can observe in almost every country is that paramedics get frustrated about non-urgent calls. Like you do all this training, you train in the academy, you train for the most life-threatening calls, but then you actually work in the field and you realize that most of the calls are not the calls you trained for, so they're non-urgent. And people also get sometimes really cheeky about calling. So, for instance, abdominal pain for 3 days, and they call you. They call the emergency service at 4 in the morning. All of these calls frustrate EMS staff, and it's one of the reasons. Another reason is like not competitive salaries in many regions. Also, a lot of pressure, a lot of responsibility, but sometimes not being able to perform, but not having a lot of competencies in some areas, which can also be frustrating. And I just missed the one. I forgot about the last point I wanted to say, but basically frustration about there's a mismatch between what you sign up for and what you actually get when you practice paramedicine. Okay, thank you.
Thank you for that insight. I think those were some really great questions and definitely challenged our kind of thinking about things, especially with that telemedicine and those cross-border challenges. Yeah, so thank you, Gabriel, for sharing your expertise with us today and your lived experiences. Really appreciate you taking the time to speak to all of us. Yeah, we'll move into our last speaker of the night.
Thank you. Bye.
Awesome, thank you. So our last speaker is Manisha Pantha Bhandari, an epidemiologist and disaster management specialist with over 10 years of experience in emergency response and public health. She holds an Erasmus Mundus Master's in Public Health focused on epidemiology and disaster management. Her work includes emergency medical services, disaster impact assessment, and health system resilience, with recent research on EMS reforms in Ukraine with the University of Oviedo and WHO partners. She's also worked at CRED in Brussels, trained responders across Asia, and supported disaster risk reduction policies in Nepal, and published widely on disaster and public health emergencies. So with that, I'd like us all to welcome Manisha to speak to us today. Thank you.
Hello, everyone. Thank you very much for such a lovely introduction. Thank you very much for inviting me here. And I'm so glad to be here to share my experience about research that I have done. And basically, my experience as a disaster preparedness and emergency response officer and specialist for over a decade. And mostly I've worked in Nepal and other 6 countries in South Asian regions. And today I'm going to share about my research project that we did with CRED, and that is basically mostly based in Nepal. Let me share my presentation now. Is it visible?
Yes, it is. You just have to, yes, put it in present mode. There you go.
Okay. Thank you. So basically, when we talk about disasters, I think you should consider our regions where we have all type of disasters, and we are still catching up with our disaster preparedness protocols and capabilities. So if we are talking about disasters, I think you name it and we have it, like in Nepal. So basically, we are in my presentation today, I will be mostly talking about 2015 Gorkha earthquake and my research based on this. And also we have a new approach to measuring disaster severity that comes with this study. Also our fellow from this study group. Years of life lost analysis for disaster victims. So this is very interesting. And also survey findings from Nepal on emergency data collections. So basically this is based on all the published work. So when we are talking about Gorkha earthquake, it's still today, after 10 years, we are still giving this example of Gorkha earthquake because there are so many things to learn from this earthquake, because some things we already did before 2015 earthquake. As a disaster response worker, I can advocate this. There were a lot many things in terms of response, in terms of preparedness that we have already done. But then 2015 Gorkha earthquake taught us a lot many things and identified a lot of loopholes that were in our preparedness plan, which was not working during the disaster. So basically, just to give a little introduction about this event, it was on April 25, 2015, and 7.8 magnitude earthquake hit Nepal. So recorded deaths were 8,970. Well, there are lots of numbers that you can find, but then this is the number that we have used in our research. Well, even then, there were lots of studies. Okay, I cannot go to the next slide now. I don't know what happened. Let me do it one more time.
Yeah, I need to reshare it.
Okay. So sorry for that. And here, even then, there were lots of opinion where people were saying that the destruction due to Gorkha earthquake was less than expected, because if you know the geology, the Nepal stands in the the fault of two different plates, and the energy was so high that the experts were anticipating that the earthquake level would be much higher and the destruction level would be much higher, but it was not that much. So even they were saying that the Gorkha earthquake was not, was not as severe as was expected. But here is another way of finding the severity in level of any disasters. So there are 17 indicators based on which we are scoring, and then based on this scores we are putting it in the formula to identify the severity index of these disasters. So this was very helpful for us to understand, especially with these indicators. We also tried to identify which area needed more attention, like in terms of preparedness and in terms of reconstruction phase even after disasters. So well, this was a published work by Q, and you can find this publication online, and this is very useful tool to identify the severity index. And also there is a formula, and also there are various ways and there are various process of giving the scores for these indicators. So this is very useful tool. And we use this to identify, to see how severe the Gorkha earthquake was in terms of this formula. And we identified the severity index was high. Have a closer look with these indicators, not just a number of losses or not just the number of, quantity of economic losses that we can quantify it as a severity, but there are lots of other indicators, let's say healthcare capacities. If healthcare capacities has the highest number than others, even then the severity can go higher. So based on these indicators, we can then finalize which area, like I have already repeated before, that this is very important to understand the areas that are being affected highly, so that for the next disaster, for the preparation part, we can be more focused on these areas. And about looking and preparing for disasters, there are certain things that we need to understand. For the vulnerability aspect, we have to see what are the physical, social, economical, and environmental vulnerability. So in any community or any, let's say in any facility, let's say if we think just about the healthcare fraternity, we can also see weak hospital buildings and limited safety measures, a shortage of trained health workers, uneven access to care. So we can consider this as a vulnerability. So when there is a disaster, let's say if it is a natural or even a man-made, so because of these vulnerabilities, the hazards can turn out to be a big disaster, right? So we have another way of looking to disaster when we look at the risk. Let's say, for example, health facilities with a lack of power backup, like if they don't have a power backup. So this we saw a lot in our research in Ukraine. It's like after the attack, many health facilities were disrupted. They couldn't function normally, and a lot of them, they were complaining about power backups. Because their hospital didn't have a power backup, they couldn't continue continue the services. So if even the simpler thing like basic supplies and communication tool, even the communication you don't have, even if the facility don't have emergency communication plan, that will turn into a chaos. During disaster, the management process will become very difficult. And another important factor is overcrowding or delayed triage. So if your team has not been well trained to, perform triage, so there are various level of triage that we all know. And basically in the hospital itself, when a lot of patient comes at once, so if the if the healthcare personnel are not well trained for the triage, that can also lead to another, add more to disasters and disease outbreaks. So about the capacity, when we are looking looking solely for the healthcare facility, strong emergency plans of hospitals to manage patient flow and coordinate action is very important, because hospital emergency response plan is vital. I am sure, like most of us who are working in the hospitals or any of the facilities, they might have emergency response plans, but do we really know what it has in the response plan? We know that they have the response plan, but we don't know what is in the response plan, because if we are not being trained, or if we have not been given a drill, like when there is an actual disaster, and if you don't know what you are going to do during the event, so there will be another chaos, right? For example, if you're working in a hospital, and if you're a nurse or a doctor, and then there is a disaster, and now you don't know where to go, how to handle your patients, who does the head count, where is the place to gather, what is your communication plan. So basically this all comes in your emergency response plan. So any hospitals or any healthcare facilities should have this emergency response plan, and this comes from the experience of our assessing hospitals in South Asian regions. So regular training for health workers and good data system. Good data system is also another very important area where without which research is very difficult. We all know about the importance of data for research. And better coordination and enough staff. So short staffing also can be another chaotic, because in your emergency response plan, there is also a plan for staff, calling staffs in emergencies. And you should have enough staffs to call during an emergency and when required, and basic equipments and supplies. So all the stockpilings of emergency supplies are also equally necessary. So when we're talking about disasters, it's not just about policies and all the frameworks, it's the actual on the site when you work during a disaster and when you deal the response phase. So these all are the small and important events that that we have to think of when we are planning a policy or planning a management or response framework. So we're talking, and so this is years of life lost. So here we did a research with CRED about years of life loss in disaster. So basically, we all know about DALI, that's disability adjusted life years, which includes YLL and YLD. So here, YLL, basic introduction of YLL, that in your life process, if there is an event, if someone lost their life in that event, so remaining life span as per the life expectancy table is calculated as years of life lost. So this years of life lost is, we have seen this for, let's say, non-communicable diseases, communicable diseases, neonatal maternity, all the other sectors of health. But then we are not much looking towards these disaster victims, because it was very interesting, and this study is very unique because there is not much, previous discussion or realization of the significance. Well, there are lots of disasters in other sectors, research in other sectors of disasters, let's say disaster loss and damage and operationalization, social vulnerabilities, community disasters. But this area of looking at years of life, absolute years of life lost, was not much done. So then we came up with this research. And the results were very interesting. Let's say for the males, this is the case of 2015 Gorkha earthquake. So for male, 59.2 years of life were lost per death, whereas for females is 58.5 years. So this is also another tool to advocate the policy makers, to show them why the preparedness for disaster is important and why we need to reduce the number of loss in deaths. So this is very unique way of researching and looking at the lens of public health. There are many areas which are left out. we are mainly focused on only known areas of research, whereas these areas are equally important to, to share why the disaster preparedness is important. And further, we also was comparing it with the Human Development Index, whereas we thought that maybe those some areas which are not equally developed up as other area might have been highly impacted with these disasters. Let's say this is basically focused on earthquake. So but then research was not significant. Well, maybe it can be in some other type of disasters, let's say in flooding or other endemic cases, there can be significant. But in case of earthquake, it was not significant, where Human Development Index was not really related to, because maybe during earthquake, it's more about building types and more about the health response, how quick the response was, and how fast the patient got treated, or how fast the patient were rescued from the debris. So those were other assets also that was equally significant in this case. But then, yes, all in all, Human Development Index was not much significant in this case. And we came with very interesting study with which we could discuss and with which we could advocate about why YLL for this disaster victims is important, because when we compared it with National Burden of Disease 2019 report, which measured DALI for loss due to communicable diseases, non-communicable diseases, maternal issue, and neonatal conditions, nutritional deficiencies, and injuries. If you see in this green table here, you can see this injuries part, which is just 0.80% higher than the here we have the number. So 526,618 was our life loss years in total, which is just closer to the injuries of this year. So let's say, for example, this report includes this number comes from this report of one whole year, which is 2019, and which we can say that the one single event of earthquake killed as many people as were killed by road accident or any other type of injuries for that whole year. So we can say how adverse these disasters can be. And this is not just an earthquake. There can be other measures of, we can measure this type of, deaths and compare it with other type of your DALI's indicators, and then compare it with the disasters. And then we can advocate why this is so important for us to understand disaster management aspects and preparedness for disasters. So I was also explaining about the survey that we did in Nepal for the data analysis, data collection process. So because we are still very, at the stage of learning and trial and error phases, and our databases systems are also not very unified. So there are lots of organizations which collect data based on their work and for their own, report purpose. So we were doing this research with 17 different organizations, very well-known organizations who were working for disaster management and humanitarian aids in case of Nepal. So mostly we found out that organizations were collecting data for the real-time data during disasters, because which is very likely that they would be needing it for the humanitarian aids and the reporting purpose. And in the recovery phase, mostly they were focused on damage assessment data. For the recovery phase, they have to equally, distribute the aids and everything. So this was not consolidated anywhere. Like they have the individual data, but they didn't have a central database system where we could get this data from. So individually, we need to find out those organizations who were collecting these data and then ask data from them. So this is also a very important aspect where public health specialists should be advocating about having a database system and centralized database system, I would say. So here, there are lots of ways they are collecting data, and And when we were focused on health-related data collections, some organizations which were specifically focused on epidemiological aspects and public health focused on public health research, those organizations were collecting data related to report cases, number of deaths, case fatality rate, and those related to epidemiology. And those data were also not equally or easily available. So also the way of collecting data were very different for different organizations, and some of them were using satellite and of the remote sensing data, and some of were just relying on news reports and media. So it was very interesting for us to know that some organizations were solely reporting numbers of all these indicators solely based on news reports and social media, and those were then forward used as the resources for research. So you can just imagine how could be the quality of research. So as a public health, from my experience working in disasters solely for response and working with the under the debris, and then coming now as a public health specialist, I can clearly see the difference between how these organizations are merged together. So public health workers, they are not aware of what disaster management sectors is doing, and disaster management sector is not much focused what public health sectors are interested in. So these two areas, like coming from my experience and my reason, these are very complicated. So advocating and going to them and telling that you both are same, like disaster management and public health is interrelated. We need to have solid evidence, and bringing it as in a very strong voice is necessary, and we are still in the process. So I'm now concluding my presentation with a few experiences that I would again share here with a strong, how do I say, let's say with a strong voice, a strong note. Let's say disaster work in public health covers many things that shape how people are protected, and hospital and clinics needs clear plans. So any of us who are here should now think about having such emergency response plans in your work area, or even for yourself, or even in your universities, anywhere, like wherever you are going, and wherever there is a potential of having disaster, or wherever you see hazards, you should know what is the emergency plan of that area, so they know what to do when there is an emergency. So health workers needs regular training. So just imagine, for a simple example of fire extinguisher. So you might see fire extinguisher everywhere in the building, but how many of you know how to use it, right? I mean, these are very simple things that we should be, if we are thinking about disaster, we should think about us first, me, because it starts from me. The preparedness starts from individual level, then it goes to family, then community, then country. So, it should be first become as a culture. The preparedness should be a culture. And good data always helps you understand what happened and what support people need. So there's still space to learn more and improve system and strengthen care for future disaster. So with this note, I would like to conclude my presentation, and I'm happy to have any questions you may have. Thank you.
Amazing. Thank you so much, Manisha. It was great to get your insights as well. What a very interesting talk. And even just to see how Rafael, maybe the organizer of the Erasmus Mundus, and then you having also taken that program. So very cool to also see those connections coming through. A quick question that I kind of had. Once again, like I said, in our program today, we've been talking a lot about shocks and resilience in Maastricht lately. And one of the things we've been talking about, especially today has been recovery plans. And you kind of mentioned it a little bit as well, but we always hear about that recovery plans and the recovery phase should be started during the shock. But do you find that that actually happens, or is that kind of a dream, a wish that a lot of the frameworks make?
Recovery phase basically is about build back better. Like it comes from the lessons that we have. Well, this is the circle. I mean, I think you remember the circle of disasters, right? It starts from the preparedness, then event, and then disaster, then happens, and then there comes reconstruction. So basically, it's reconstruction is about build back better. So whatever the faults that have happened during the event, so reconstruction phase should not be repeating it again. For example, if during disaster there is if any hospital was crushed down, and then in your reconstruction phase, it should be built in a way that it will not crush in next earthquake, right? So and then that is also another step for preparedness. So I think reconstruction links build back better to be more prepared for next disaster. So a reconstruction phase is very important phase, so that if you don't, if you couldn't handle this reconstruction phase properly, or if you couldn't learn the lesson from the event, the next disaster will be equally catastrophic, because your reconstruction phase was not good. I mean, not well planned. So I think immediately after event is a realization. So if you have a preparation, event is a realization that if your preparedness worked or not. So if your preparedness worked well, yes, reconstruction phase can go further within the same direction. But if the preparedness didn't work during the event, the reconstruction phase has to have a new change from the lessons learned.
Yeah, thank you for that insight for that question. It really answers it well. Does anyone have any questions for Manisha here? You can either put them in the chat or just unmute yourself. I know we're getting kind of late, but still would love to hear some insights. I guess I do have another question as well, more that kind of personal one similar to Gabe. I'm always very interested to hear maybe what sparked your interest in being involved in emergency and disasters help, especially with that like public health lens.
Yeah, I'm a nurse, and so while I was working in nursing field in Nepal, so we had lots of events and disasters that I've told you, and there were lots of cases where disasters was disaster was not taken very seriously. So when more than expected patients comes at once to the hospital, everyone used to be chaos. So everything used to be very chaos, and so we had to have discussions about how to manage well and how to have this emergency response plans. And then somehow I got linked to this disaster field, and then I got to understand that emergency response is very important. So I developed that interest of developing emergency response plan. Then I came back to understanding why disaster is important in the health field. So hence, since then I am working in disasters, and I'm really proud of it, because we have done wonderful works, and we have worked with Program for Enhancement of Emergency Response, which works for 6 countries in South Asian regions. And basically, we work for disaster collapse structure search and rescue and medical first response. So yes, this field is very interesting. And now coming with the public health, I really see the importance of coming to this field now. Yeah, I mean, it's a very interesting field.
It is quite interesting, especially I think with just how the world is going, having gone through COVID, and then even in the European context of having the invasion of Ukraine, and then just a lot of things happening all over the world. This is a very real topic that is going to definitely continue to get more traction as we continue going in these next couple of years. Does anyone else have a question for Manisha before we kind of close this off?
Hi, I have a question.
Perfect.
I wanted to ask about advocacy, because you talked a little bit about it, and I wanted to know if you had any experience doing advocacy in the governance level.
Yes. Before 2017, government didn't have any policy regarding disaster management. So we were advocating for having a proper disaster management act, so that all the ministerials, so there were ministers, like for an example, if there was an earthquake, the management would be done by whole health ministry. Then health ministry would ask other ministries to act, and then there were lots of mismanaged, and the response was never well done, I mean well planned. So after this act was implemented in 2017. So now there is another organization, let's say another department under the health ministry, which is known as National Disaster Response Department. So now all this disaster management aspect is handled by this department now. So this has made our work very easy, because all the disaster management activities are handled by this, and we do not have to go through all the other ministries. So we had lots of advocacy programs advocating about this. We were advocating through workshops, through seminars, and we were inviting all the personnel in ministers and convincing them why this is so important. So yeah, I used to work in National Society for Earthquake Technology in Nepal. So that with these organizations, we were really in developing framework. We were also working with the team in developing the framework. So yes, we were finally able to have a new department now.
And do you feel like it's done a great difference?
Absolutely. Like I said, the flow of management is very straight now. Earlier, it was very diverse, and by the time we get to the home ministry through, for even a simple management, it was very difficult, because there were lots of layers to, report. And because there was not a direct person to report, there would be very difficult in even the time of response was very late. Because for let's say in Nepal, in case of Nepal, a lot of responders are from security personnel, from security, army, police, APF, armed police force. So these are the major responders in Nepal, in case of Nepal. So to deploy these personnels also, we had to have a lot of layers of ministerial permissions. But then now, since we have this dedicated department, it is very easy, even to, for the communication flow is also very easy. Management flow is also very easy, and things are now changing. So we are hoping that the next disaster will be better planned.
Thank you very much.
Thank you.
Amazing. So with that, we will come to a close for tonight. So I would just like to say thank you again, Manisha, for volunteering your time to speak with us today and sharing your experiences.
Thank you.
Yeah, it was great to have you. And then also, I just want to say thank you to all of our presenters. I know we already had Andrew and Rafael leave us, but to Manisha and Gabriel as well, just thank you for sharing your insightful presentations on emergency and disasters in public health. We really appreciate our speakers for volunteering their time to take part in this. And as well, thank you to all our participants today for coming to spend this time with us and to learn more about areas of public health through the EPHSA talks. With that, have a great night, everyone. Thank you all for coming.